crossed.
So good morning and welcome to our first live Q&A session of the conference. My name is Gary Nolan, and along with Helen, we'll be moderating the live Q&A sessions throughout the course of the next 2 days. For this first live Q&A, I'm joined by Shahid and Sophie, who you've both heard from, and we will be cycling through the questions that have been pre-submitted, as well as those that have been presented live during the meeting. So to start the session, we'll start with you, Shahid, and we're going to jump to a question that was put to you in the Q&A box. And the first question is, what makes cholangiocarcinoma different from gallbladder and pancreatic cancer in terms of chemotherapy treatment?
Okay, so I know we've got a lot of questions, so I'll try and be brief. So gallbladder cancer is technically a biliary tract cancer. It's the same basic cell, the same area. The main difference is the location for gallbladder and pancreatic cancer. They are all gallbladder and all types of cholangiocarcinoma and pancreatic. All are relatively resistant to chemotherapy. They all have a poor prognosis. They all present very vaguely, but they are anatomically different areas. But the chemotherapy treatment is similar for gallbladder and the other cholangiocarcinomas.
Excellent, thank you, Shahid. So, Sophie, one of the questions that also came through to you in the live chat box is what determines surgery plus or minus chemotherapy?
So in the analysis that we performed, I think as we mentioned on the slides, we looked at any occurrence of surgery occurring within the first 12 months after diagnosis and chemotherapy within 15 months of diagnosis. And basically, if we found presence of both surgery and chemotherapy during those time intervals, we would have defined that as surgery with chemotherapy. And if we didn't find evidence of chemotherapy in that 15 months after diagnosis, that would have been defined as just surgery.
Wonderful, thank you. I hope that responds to that question. There's a question that came in from Mr. Andrew Murphy, which I think both of you may want to respond to either collectively or separately. And it's a relatively long question, so bear with me while I read through it for you. So the question is there any evidence that will better diagnose and code in that is explaining the increase we are seeing globally of cholangiocarcinoma? If so, is there also a noted decrease in the cases of liver cancer or other cancers around the gallbladder? This could provide evidence that could be used to profile the disease and used to predict the prevalence moving forward. Shahid or Sophie, who would like to start with that one?
Yeah, I could come in on that one. I guess, yeah, it's quite a tricky one because I suppose the definitive way of understanding whether the change in coding is responsible would be to go back and recode past cancers and see if we would code them differently according to today's rules. So I guess the best way to have a look at that, as Andy suggested, is to look at the interplay between diagnoses of different types of cancers, liver and the gallbladder, compared to cholangiocarcinomas over time, and to have a look if other liver cancers are decreasing and as cholangiocarcinoma seems to be increasing. It's not something we've tried to do yet, but it's something we definitely consider as a way to try and get to the root of that. But it's quite hard to definitively know, I think.
So I'll just add there, so it's a really good question. Are cases of cholangiocarcinoma going up because we're getting better at diagnosing them, right? So I don't think it's an issue about coding them, because the problem with coding is how the different types are coded, not the total number of cases. So, but it is a valid question. Are we just diagnosing it better? When a study that we did a few years ago showed that the proportion of patients who are getting histological confirmation is improving, and we are definitely getting better at biopsying, etc. We're getting better at imaging. So in theory, we might be diagnosing these cancers better. However, there was a study about 10 years ago from the US that addressed this exact question. And what the hypothesis was that if you are seeing cholangiocarcinoma more because we're diagnosing it better, then in theory, the stage of disease at which diagnosis is made should be getting earlier. And in this study, they looked at staging over a 10-20 year period and found that that we are not picking up cholangiocarcinoma at any earlier staging. And their conclusion was it's probably not just better diagnosis, but it's a real can of worms to really, really know. Unless you went back to look at the real cases historically over time, which is essentially impossible to do. But there probably is some element of that, but how much, we don't know.
Excellent. Well, I know that was a particularly tricky question, so thank you both for responding in the way that you have. So, Sophie, just onto another question that came in during your presentation, and is really around what you've seen in the work and the research that you've been performing. And the question here is you're an experienced data analyst. What, if any, have been the most surprising or unusual data that you have uncovered in this cholangiocarcinoma project compared to other cancer data projects you've worked on in the past?
Thanks. Yeah, so I think there's two things that stand out for me, one of which I'd mentioned in my talk, having known very little about cholangiocarcinoma before I came to be involved in this project. And the first one is the high rates of mortality seen for this cancer type, particularly based on some of the findings from a past analysis that the AMMF has done with NDRS, where mortality rates are comparable to incidence rates for this cancer. And then the other thing was the amount of stage data that we don't have flowing through to the National Cancer Registration data set. And as I alluded to, for things like pancreatic cancers, stage completeness has been at about 80% since 2015, but for cholangiocarcinoma, for some reason, we're seeing about 55% completeness. Yeah, that was a bit of a surprise for me.
Excellent, thank you very much. Shahid, on to another question that came through live in your session. How often do we find cholangiocarcinoma in choleristic liver disease such as PBC and PSC?
So cholestatic liver disease, where there's problems with the flow in the bile, PSC is the disease that in the Western world is the biggest risk factor. So it's the commonest known predisposing cause, and the lifetime risk of getting cholangiocarcinoma if someone has PSC is estimated to be somewhere around about 15 to 20%. With PBC, it's not so much. It's much less of a risk factor, probably similar to any background liver disease, the risk being probably somewhere between 2 to 4%. But PSC is the more risky for cholangiocarcinoma. Thank you.
So we probably have time for another 2 questions. So Sophie, just back to another question that came through. What is the 1 to 2 and 5 year survival rate for non-resectable cholangiocarcinoma based on the research that you've been performing?
So based on the research that's been done recently, I don't think the survival rates were split down according to whether they were resectable or not. But we saw sort of a varied survival from around 27% at 1 year to 42% by different cancer alliances and the past analysis that was done, but I wasn't involved in that one, unfortunately.
Thank you. And Shahid, on to another question. If you've had your gallbladder removed, are you at greater or lesser risk of developing bile duct cancer or cholangiocarcinoma?
So there's no evidence, as far as I'm aware, that you're at greater risk of cholangio if you've had your gallbladder removed. Given that gallbladder cancer is technically a type of cholangiocarcinoma because it's part of that same anatomical area, and if you don't have a gallbladder, you can't get gallbladder cancer. So your overall chance is probably less. So certainly not more, as far as I'm aware.
Thank you very much.
Can I just interject that? Is it not so that many times when people are having their gallbladder removed for various problems that then get diagnosed with a an unseen cholangio?
Yeah, so one of the commonest reasons to have one's gallbladder removed is gallstones, and people with gallstones are very common, 20% of the population. Not everyone gets symptoms, but some people with gallstones get recurrent episodes of what's called cholecystitis, inflammation of the gallbladder, which can be very painful, and that's an indication to have the gallbladder removed, because chronic irritation of the gallbladder is a recognized risk factor for gallbladder cancer. And sometimes when people have their gallbladder removed, incidentally, when they do the histology and look at it, there is already a cancer developing. Absolutely.
Thank you.
Excellent. Well, that actually rounds us up nicely. We've now come to the end of this first Q&A. We're now going to break. Thank you for your participation. Thank you for your questions. And we look forward to seeing you join future sessions. Thank you, Shahid and Sophie, for your contributions as well.
Pleasure. Thank you.
Thank you, everyone.
Dialing in, everyone.
Thank you.